pay off all my bills.
Yeah.
And then give the rest of it away to people that need their bills paid off. And then I would just work at like a dollar store.
I'd get a million puppies.
I'd get a basket of puppies. Oh my gosh, I'm gonna have a seizure.
We'll finish out this particular presentation. If we can, it'll help to get more involved in the interpretation side of things. So it could be good. What I'm going to do here, let's just see if we're on the same page here. This first case, can y'all kind of read that in the back? Can you? Can you read that in the back?
Yeah. Yeah.
All right, everyone, see what you think about this one. Here we did there's the flow volume loop. Again, the most thing we're interested in is the expiratory portion. They didn't do the inspiratory part. Here's a volume time tracing. Let me just comment on something. I know sometimes I'm going to be guilty of this, and sometimes like that little exercise we did a few moments ago, where I gave you just the numbers, there was the grid we filled in. You need to see the graphs too, just to make sure it's a good quality. And sometimes some of the graphs, you can look at the graph right away. If it's very crescent shaped, very moon shaped, right away you know you're talking about obstructive lung disease. The shapes of them can be helpful, right? And so, but sometimes I'll just give you the digital numbers of it, and you just have to do the best you can. You have to assume it's of good quality, right? So see if you can go to this and actually do the interpretation. Or maybe we'll do this one together, right? Just because you see we've got a lot of numbers here that we might not even want to look at necessarily. So I look up here, this is a spirometry of good quality. There's no coughing at the beginning. It looks like we got it clear. It flattened out here. Maybe could have flattened out a little bit more, but it looks like they went at least 8 seconds. So the first thing I'm going to do, what's the first value I'm going to look at? Well, I'm going to look at the FEV1 divided by the forced vital capacity. So we come down here. Let me make a note here. There is no such thing as a percent of predicted for this. Okay? Don't even look at this. This is not useful at all. This is one of those things with the PFT software. They say, well, we can do this. Let's go and check. You don't even, what we want to look at is the actual value, the FEV1 divided by forced vital capacity. This is 80%. Alright, so it's 80%. Alright, so then we come down here. What about the next thing I'm going to look at is, so it's within normal limits, right? So I look up here my forced vital capacity, 116% of predicted. What do you think about that? It's within normal limits, right? 80 to 120. There's no disease process associated with greater than 120%.
I thought you said don't look at the percent predicted. Yeah, you said like a run.
Well, you have to. You don't look at it for this one. This is the one that we do not look at. FEV1 divided by forced vital capacity. You have to look at this value right here. All the others we're going to look at percents of predicted, because we cannot memorize, these numbers, what's normal for them. We have to use the computer to do the percent of predicted, right? So this is 116% of predicted. That's within normal limits. And then I look at the FEV1. Again, that's within normal limits. Then I'd come down here to look at the peak flows within normal limits. I would not even really look at this. This stands for forced expired flow at 50%, like halfway through their vital capacity. We haven't even talked about that. I wouldn't even look at it. It's not used for interpretation. This FEF 75, after they've blown out 75% of their vital capacity, look at the flow during that time. This is not standardized. I don't even look at it. Sometimes you look at it to get a general gestalt of what the results are like, but it's not used for interpretation. Right, so then we come down here to the bottom here. Now we could look at the FEF 2575. Greater than 60% is considered normal for this. So what do you think this particular PFT would be interpreted as?
Normal.
It's normal. So don't be surprised on an exam you could get normal. Right? People are always looking for diseases everywhere, right? You could get something that's normal. So we'll look at another one here. So, look at this one, they're not giving you an idea of what the predicted would be for this. Of course, here's the full volume loop. It looks like it's of good quality. This volume time tracing, it looks like they exhaled at least like 8 seconds. It could have blew out a long time. Right, looks like. So, first thing I'm going to do is look at my FEV1 divided by forced vital capacity. This is we sometimes call it the FEV1%. So you should be familiar with, if it's an old school PFT equipment, the FEV1 divided by forced vital capacity, the other term that's used for that is FEV1%. This is the same thing as FEV1 divided by forced vital capacity. Don't pay any attention to predicted, right? But we want to see what it actually turned out to be. It turned out to be 100%. That's really good, right? So then the next thing I'm going to do is I'm going to go up there and look at my forced vital capacity. What's that? 20% of predicted, right? And it looks like you look at the FEV1, it's 20% of predicted, right? And so right away, of course, you generally want to look at everything here. The peak flow is like 38% of predicted. You know, I'm not really going to really look at this. So what would you consider this one to be? There's no ifs, ands, buts about this. Is a restrictive lung defect. That's the other thing. You need to be working on this. Later on, we're going to have exercises where we have all of the results together. Like next week, we're going to have a lab where part of it's interpretation. You need to be able to look at just spirometry and get a good idea of what's going on here. You need to be able to look at just lung volumes, which we're going to talk about here in a moment, and be able to figure out what the disease would be. And so, and then including the diffusion capacity can help separate things out further. Now, one of the things any pulmonologist would say for this, they would make a comment that they would like to see lung volumes on this person too. So if the spirometry is revealing something that shows a restrictive lung defect, they're going to ask for lung volumes to be done too to confirm it. They will ask for lung volumes to confirm it. By the way, I'm not going to have questions on my exam where you could have combined problems. You realize someone that has COPD, let's say, could, let's say they're massively obese, right? Or maybe someone that has someone has COPD might develop heart failure. And I'm not sure if the heart failure sometimes can back up fluid into the lungs and make them stiffer, right? And so, you know, I'm not going to give you mixed diseases, but they really do exist in reality. You could have combined obstructive and restrictive defect. But right now, let's just get the straight ones addressed, right? I won't give it to you as a test, but I think next week when we do our little interpretation, there could be some one that's combined. Okay.
What's the extent of severe restricted?
We don't have information. I would say this is severe. We're not going to get into quantifying the severity of restrictive defect. Again, you have to have lung volumes to do that anyway. It's pretty bad. Okay, so if you look at the quality of this tracing, just looking at this, what would you? I know you've only seen a couple of these. Does this look normal? No. Does it look like there's good effort? Looks like there's good effort on the extrinsic part. I'll tell you what might have happened here to create this. They took their deep breath in, they blew all their air out, and it could be what they did is maybe it was out of their mouth for a moment. They put it back in. And they sucked in, because you see how there's this big gap here? This is not, normally it should go like that. It should be picking up right there, but maybe their nose wasn't clamped and they breathed into their nose at the very beginning. But anyway, this expiratory one is of good quality. What else do you, of course we can look at this one. What does it look like just from that? No, why did you say that? It's scooped out. Looks like, just looking at this, it looks like it's obstructed. It's scooped out. It's crescent shaped here. Note, if you look at this, the flow rates are not coming out very fast on this. So then let's go, we're gonna go right here to the FEV 1%. We're gonna go what the person actually did. They did 49% of predicted. So right away, what do we know? It's obstructive. There's no effect, they have obstruction. Then I'm gonna come up here, look at this, the forced vital capacity looks like it's within normal limits. The FEV1 is 56% of predicted, which is reduced. So then you come down to peak flow is reduced. We don't have to look at this one, but it's reduced too. So what will we interpret this as? It's obstructive lung defect. So what we could do, if we could actually quantify it by looking at this, it's 56% of predicted. Remember, if we're going by the goal, right? Remember, greater than 80% for this value right here is, remember you have your FEV1 divided by forced vital capacity is reduced, so you don't got obstruction. If the FEV1 is greater than 80%, then it's mild. And then we go 50 to 80 is moderate. So this will be in a moderate. So strictly speaking, if you had to put a specific grade on it, this would be moderate. Stage 2, moderate obstructive lung disease. Notice a lot of times, this is really reduced too, so we'll move on. So let's look at this one. Looks like this is the pre and post bronchodilator one. And so usually when we're doing the interpretation for this, a lot of times they'll look at, for the interpretation component, they're going to look at the post one. So let's look at the post ones here. So we're going to look at the FEV1 divided by forced vital capacity post bronchodilator. Looks like it's what, reduced, right? 67% of predicted, right? So then we're going to look at the forced vital capacity is 120% of predicted. The FEV1 is 93% of predicted. So we know we got, because this is reduced, we know we have what? Obstructive lung disease. What's happening here, this is where, if you look at these two, you say, wait, these are within normal limits, but because what this is telling you, they can breathe in deeply, or they can blow a lot of air out, but when it comes to per unit of time, when they're doing it at per unit of time, they don't blow out as much when you look at a ratio of it. So then you come down here, we can look at the peak flow is 86% of predicted, and if you look at this FEF 2575, it's markedly reduced, right? So what would you characterize this as? It's an obstructive lung defect. We're probably catching it early. It's probably early. But this is an obstructive lung defect that we have here. In fact, you can look at it. If you use the asthma COPD guide, you use the COPD goal, because this is greater than, we got FEV1 divided by forced vital capacity less than 70%, right? So then you look at this is greater than 80%, right? This would be in the mild category, right? This would be mild. If you want to put a grade to this, it's obstructive defect. If we want to be more specific, we would say it's mild.
So maybe what I'm taking away from this, because I feel like this is the FEV1% and the FEC. If it's less than 70, most likely it's an obstruction.
Yeah, if this FEV1 divided by forced vital capacity, if it's less than 70%, it's obstruction.
So then, is that always?
Always.
Okay. So then if it's more than 70, it's more like it's less restrictive than normal.
That's right. She just said it perfectly. She said if this comes out to be higher than 70%, you either have it as a normal or it could be a restricted.
So it's kind of like one of those situations where you have to start out, kind of like the ABG, you have to start out with your FEV1 and then kind of rule out obstruction first, and then go to your FEC and your FEV1 and kind of rule out whether it's going to be normal or
Right.
restricted.
Go to this one first. Absolutely, go to this first.
So if it is less than 70, you don't have to go any further.
Well, you know it's obstructive, but it's good. You want to get a general, but this, looking at these two, it depends on what you know, the physician, when they do their interpretation, they're gonna quantify mild, moderately severe, and severe, very severe, the 4 categories, right? They're gonna grade it according to that. Now,
So,
my multiple choice questions, I'll probably have 1 or 2 where you will have to put down the grade that it is, like, but most of the questions might be, it's obstructive, or it's restrictive, or normal. Yeah.
When you're classifying the type, mild, moderate, are you looking at the post-bronchodilator
Yes.
ratio?
Post. Look at the post one. So then the next thing we have to look at is, of course, you get single pre, of course it's worse. And then you look at the percent change. Now, when you do these percent changes, what they're doing is they're taking the post, let's look at the FEV1, they're taking 3.11 minus 1.77 divided by 1.77 times 100. That's how they got this number here. Obviously, you can see, you can't take the percent predicted. Look, these are only, you know, obviously this is not anywhere close to 75% change, right? You have to take the real value. So when you're doing percent change, percent improvement, for like bronchodilators, you take the real value, post 3.11 minus 1.77. We always divide by the baseline value, the pre-value, which is 1.77 times 100. That's how they got this. Don't do the percents of predicteds. It doesn't work that way.
So when you're grading, you're gonna look at the percent change, not the percent predicted.
All I'm saying, all we're doing now, for looking at the percent change, what we use for the interpretation, they use the post for interpretation, like we just did a moment ago. But then you want to see, do they have significant change after they had the bronchodilator? And then that's where you use this percent change to see if they had improvement after a bronchodilator. I don't know if that answers your question. Don't use the post for your interpretation if it's available to you. And then you have to use the percent change by going, you know, of course they give it to you, but I showed you how to do that value.
So it's post minus the
Pre divided by pre times 100.
Okay.
Just like we did with peak flows, post minus pre divided by pre. You always divide by the baseline. If you were to reverse those, you did 1.77 minus 3.11 divided by 1.77, you'd still get the same percent change. Just you'd get a negative number. You know, but you would know that they actually, you'll know which way change the result.
So the reason that it's mild is it looking at the 93% or the 75?
No.
It's looking at the
This.
okay, so that's what I need.
All this is going to tell you is if they responded to bronchodilator or not.
Okay, that's what number I need.
Look how low their FEM 2575 is, very markedly low. Let's look at this last, this is the last one here. Oh. So, let's look at this one. Look at the FEV1 divided by forced vital capacity, 89% are predicted. So, right away, like Andrea was saying, it means we either have normal or restricted. We don't really know yet. So then we come up here, that's within normal range. That's within normal range. Peak flows, normal range. So, what would you, now, first let's look at this. To me, it doesn't look like we've got a good bust at the beginning of this, but it looks like their peak flow is still a good value. It looks like for some reason, again, something's going on here. They took their mouth off the mouthpiece and then they breathed in. So the quality of this is a little bit suspect. I'd like to see all three of them. All three of them look like that. So what would you interpret this as? Normal. All right. So you know about peak flows. So there'll be peak flow calculations related on the, you'll be able to interpret it, because it's used as the asthma guidelines. So you already know about this. You know how to calculate your zones, you've already done this before. I'm not going to have you, I'm not going to go over it now. Now, if you look at this, this is taken, I'm going to give you a scenario here. This patient that has known asthma, let's say they're coming in and the physician asks them 2 weeks before they come in to actually do a diary of what their peak flow is doing. Right? So they're doing peak flow, they might be writing comments if they were short of breath, that they had to use their albuterol or not, so they're keeping track of that. And of course you can see, usually you're going to get your peak flows a little bit higher in the evening than you would during the day. I assume these two are the same day. You know, usually you'll see, looks like this day was about the same. Sometimes it's not though. So here's the, we have the highest and the lowest here. So if we look at that, I wish I should have had, we're going to calculate out the percent variability here. We could, so if we look at percent variability, we will take the highest value minus the lowest value divided by the highest value times 100. That's how you come up with peak flow variability. It was on that slide several ago. So what's considered a normal variability during the day? Does anyone remember that? Normal variability over the course of a day is about 20%. That's considered normal. Because you know, early in the morning, people's peak flows are lower, which is expected, part of our circadian rhythm, part of how things are. And then what will happen in the evening, cortisol levels, other hormones are higher at that time, you tend to get a higher one. So normally you expect to have some variability there. But if it gets to be more than 20%, that's considered excessive, and the patient might need to have more controller medications if it came out to be more than 20%. So this came out to be 15%. So this person is given just this information by itself. It looks like there's not much variability in their asthma. Now you have to talk to them. Do you have any symptoms? How are you using your albuterol? You know, all that kind of stuff. But just by looking at this, there's not excessive variability. More than 20%, it might not be under good control.
Just to make some modifications to match those, like just kind of, do 5% lower or 5% higher. Is there a midway on that?
No, I see what you're still going to use their symptoms. As long as it's within 20%, you're going to use their symptoms. I'm doing great, doc. Everything looks good. I don't have any problems at all. Versus if they're saying, yeah, I had to use my albuterol quite a bit, during this time frame. This is another piece of information. You look at this particular patient, look at this scenario, and we could, of course, figure out, but you can see there's a big changes that are going on here. They're untreated with their asthma. There's a big difference between this is the morning and this is afternoon. They start them on some, maybe they start them on some type of inhaled steroid, and of course it takes a couple of weeks for that to really start working, for inhaled steroid to start working. So you can see as it's going up here, it's now, this is pretty stable now, but at this stage there's a lot of variability there. See how that can be helpful? You see there's a lot of variability here, right? And of course this is just coinciding with what you might already know. This is very straightforward, but sometimes it might be more subtle. And then talking to, the patient just a couple of weeks before they come in, or maybe this is when they were having a lot of trouble. Doc, I need to come in. They come in to have an office visit. They start them on the inhaled steroids, and then they say, I want you to keep track of your diary over the next couple of weeks, right? And then over the next couple of weeks, I want you to call the office and tell us what your peak flows are like. Or they might tell them to come in. Anymore, it's getting to be where I wouldn't be surprised at all. I'm sure it's available. Electronic peak flow meter could be in the person's home, where the information could be, sent up from the World Wide Web and the cloud, right? And then the physician's office could be looking at that information, real time. So you see how that could be useful. But here, I'm sure the person's under control now. That's not much of a difference. We could calculate it out. Have I used this scenario with you before? What do you think's going, this is looking at someone's peak flow, a diary here that's going on. So let's pretend like you're the pulmonary, you work in a physician's office, and say you work at Pulmonary Associates office or Lexington Clinic, and they're coming in and you're looking at the diary. If they haven't seen the physician yet, you're getting ready to do PFTs, and look at the diary. What do you think's going on here?
Probably don't know how to do it.
Huh?
Maybe they don't know how to do it.
Well, maybe they don't know how to do it. Here's it looks like there's major spikes that's dropping down here. Notice is it happening any particular time?
What does that sister say?
Looks like it's, does it happen on Friday?
She goes to their friend's house on that day.
She's not taking her medication over at her friend's house.
Okay, maybe, it looks like it's happening, it's hard to tell, is it?
Friday.
I think it's Friday night.
Maybe she's exercising.
Fridays, something's happening on
Not
Fridays.
taking her medication.
Here's the deal with this, the person goes horseback riding on Friday, she has her lessons on Fridays.
She's allergic.
She's continuing to take her medication, right, but she has trouble, shortness of breath, she has, riding horses, there's a major amount of dander, major exposure to pollens that can happen during that time. So this part, you'd be querying this person, it looks like your peak flows are dropping on Friday. What are you doing on Friday night? So Friday I go to school, and then when I get out of school, mom takes me horseback riding. Horseback riding. Now, that doesn't mean you have to stop them from horseback riding. Maybe they take, maybe they use albuterol before they go horseback riding, right? You continue, looks like they're under good control. I don't know. We have to do the calculations on this to see how much variability there is here. Looks like it could still maybe use some more controller medications. Looks like this day here, looks like there's quite a bit of difference. But they're running into a trigger for their asthma. And they say, what happened on this night? Oh, that night I had a party I went to. One of my friends had a birthday party, so I went to that. I think they all went back around. This looks like there could be excessive variability here. We can do the calculations on it. You see how that can be useful? They do the same thing. So say someone has an occupational exposure that could be causing lung problems in their breathing, and sometimes they'll give the patient a peak flow meter, and they're doing it before. They might even do the peak flow more than twice a day in some cases, and that might help figure out what the actual cause is. Realizing though, you all know from what you learned before, asthma has two components to it, right? There's a bronchospasm component and there's an inflammation component. Sometimes the occupational, they're working and they're getting exposed to these fumes, let's say, or whatever, and maybe, how long does it take for the leg response, for the immune inflammation response? It's hours, right? We're talking 6 hours plus. Well, maybe they get home from work and that's when they're short of breath, right? And so it can be hard to tease this out sometimes. You cannot diagnose someone with a peak flow meter, but it can be helpful in following the trends. So it can be very helpful. I'm going to ask you to, you already have an assignment for Wednesday already, right? You know, you're doing spirometry 1, spirometry 2, lung volume 1, and lung volume 2. Add this to the measure. There's an error on this particular diagram here, and that y'all see what it is. What should this be right here? Instead of 50%, it should be 60%. This should be 60% here. So when you're calculating out your zones, what happened this is an older thing, and asthma guidelines, they change like things do. This should be 60 to 80% of the personal best is yellow. Less than 60 is the red zone. I fixed this before and I forgot to do it when I put it on this presentation. So you're going to calculate out the percent variability. You're also going to figure out the person's green zone, yellow zone, and red zone.
Are you talking about for this particular slide we're doing this?
Yes.
Okay.
And you're going to turn it in, just answers on a separate piece of paper. You'll put the answers down. This is a good example of what could be used in a peak flow diary. write down how they're doing. So, now we're gonna look at the loops. The thing to note about the loops here, just to give you orientation, these dotted lines here represent what would be considered normal. Right? The dotted lines are normal, and sometimes what happens is if what the patient actually did overlaps with the dotted line, you won't see the dotted line. So the next thing to note, this, all what's going on down here is showing what's happening, this is this is inspiration, right? And this is expiration. So this first half, this top half of this, is with the person breathing in. The bottom half of this is with the person blowing out. I'm just giving you an orientation of what we're looking at here.
I thought that was the heart, so it's a good thing you explained.
What's that?
I said I thought that was the heart, so it's a good thing you explained.
Right, this is the heart right here.
Oh.
Actually, the space. This is the space.
Well, then where's the loop?
The loops are up here. Let me finish going over it. This top part of all this is looking at when the person's inspiring. This bottom half is with the patient expiring. This is the heart, the space between the lungs where the heart would lie. Right? So what this first one's showing you, I want you to notice something here. If you look at this, this is normal. The dotted line is representing normal. And if you look at this, notice there's a truncation of the expiratory part, and there's a truncation of the inspiratory part. Right, so we're going to, let me, I can see there's still a little bit of, let me show you some other slides. We're going to come back to this. I probably need to define this before we go to it. Of course, interthoracic is any structures, airways that are inside the chest. Right, so interthoracic or airways within the chest. Basically, anything below the suprasternal notch. So any airways that are below this, that is called intrathoracic. Okay. Now let me ask you this. When you breathe in, what happens to the airways that are inside the thorax? What happens to your, now the trachea, because it has cartilage, it really doesn't move much, and your right main stem, left main stem, they don't change. You go down a little bit farther, they change. When you breathe in, what happens to your airways inside your chest? They get bigger, and they get longer. When you breathe in, the airways inside the chest get bigger and longer. Of course, when you exhale, they're getting smaller and shorter. Versus if you look at an extrathoracic, what happens to, when you breathe in, what happens to the airways, let's say, that are outside of the chest, that are extrathoracic? When you breathe in, what happens to them?
They become small.
They become smaller. Have you ever noticed when someone has really bad snoring, they snore on inspiration and expiration. When someone first starts snoring, whether they're falling asleep when they're snoring or if they're depending on their weight as they gain weight, usually you hear the snoring on inspiration first. Right? Because what happens when you breathe in, the tongue and the structures come together. Right? And then when you exhale, they get bigger in diameter. Versus it's opposite what happens inside the chest. So does this make sense what we just did there?
Yeah.
So then we got this variable obstruction. So realize what we're talking about here. Airway diameter changes more on either, when you have there's a variable obstruction, it means the airways are changing, the diameter of the airways are changing on inspiration or on exhalation. Either one, you have variable. Now what we can do is we can figure out if it's in the chest or outside the chest. So if it's within the chest, what's going to happen, because the airways are normally getting smaller when you're exhaling, does it make sense? If you already have a narrowing there, it's going to be exaggerated on the exhalation phase. If it's in the chest, The airways are normally getting smaller when you're exhaling. It'll be exaggerated. Let's say there's a tumor. There's a tumor down here, being fairly far down, right? What'll happen when they forcibly exhale, the exhalation is going to be truncated. Versus, let's say, if the problem is, let's say you have a vocal cord polyp or vocal cord paralysis, or there's a big goiter that's pushing in on their neck. What will happen here when you breathe in, because this problem is extrathoracic, you're going to find the truncation occurring on the inspiratory part of the loop. Right? Because when you normally breathe in, it becomes more narrow because the vocal cords are paralyzed, because the airway here has maybe there's a tumor up here outside the chest. It's going to be the inspiration is what's going to be affected. So does that make sense? Because when you realize what normally happens to an airway, right? What happens during inspiration, if it's inside the chest, it gets bigger in diameter. What happens during inspiration, if it's outside the chest, well, it gets smaller in diameter, right? So, the opposite is true as well, right? So, now let's fixed obstruction, and we'll go over that one, then we'll go back to the slide. When it's fixed, both inspiration and expiration are affected equally. So you cannot tell if it's inside the chest or outside the chest. You can't really tell. It's fixed. Both of them are being obstructed. So let's say you have a tumor up here and it's so bad, or for whatever reason the anatomy is such, it affects, it's narrowed on inspiration and expiration equally. You have a tumor in here and it's affecting both inspiration and expiration equally. You couldn't tell by a flow volume loop where it would be if it's fixed. But if it's variable, you can. So if it's a fixed obstruction, it could be inside the chest or outside the chest. You cannot tell. You're going to have to do a bronchoscopy. You're going to have to do other tests to figure out where the obstruction is if it turns out to be fixed. So now let's look at this. This is showing someone that has this is what would look like for a fixed airway obstruction. So this example A is showing a fixed airway obstruction.
Just the same.
What's happened, right, both expiration's truncated and inspiration's truncated. What these lines are trying to show here, they're giving an example here. You could have a big goiter or some problem up here, a tumor. When they breathe in, it's narrow. When they exhale, it's narrow. Or it could be, the tumor could be in their trachea, let's say. It doesn't matter. When you breathe in and you breathe out, it's equally affected. That's a fixed airway obstruction. It could be in the chest, or it could be in the chest or outside the chest. Now you look at this one. This is extrathoracic, right? These little narrowings here are showing it. It's outside the chest. It's above the suprasternal notch. Where do you see the truncation? It's on the inspiratory part. The exhale part looks normal. This would be a variable extrathoracic. Variable extrathoracic because it's affecting the inspiratory part of the loop. Then you come over here, maybe there's a big tumor that's inside the person's airways somewhere. If you look up here, notice what's going to happen when you breathe in, it opens up here, but notice when they exhale, this is exaggerated. It's exaggerated on the exhalation. And so you have truncation of the exhalation part. This would be a variable intrathoracic obstruction. Variable intrathoracic obstruction because the expiratory part of the loop is what's really affected. So you see, this is invaluable. If you look at this is where loops can be real helpful. They can help you identify where the obstruction actually is. Now what you'll find is there's the exercise that's called, I think I call it flow volume loop exercise. You'll use this information to help you interpret it. Now what you can do, a couple of the answers on the flow volume loop exercise, you can have two answers can be correct for a couple of those. And we'll go over those ones. So remember that's due on Wednesday, the flow volume loop exercise. Just realize there's a couple answers that can work because you have a fixed airway obstruction, right? It could be due to, it could be outside the chest, or it could be in the chest. So a couple answers. Don't be surprised you talk to someone else, say, I got this for that, well, I got that. Well, it could be you're both right. Can't really tell. Look at these particular loops. Can you see how this can be useful to look at here? In emphysema, you have the crescent shape. Asthma, it's not quite so crescent shape, but it could be. If someone has severe asthma, it could be just this much of a crescent. Restriction, it looks pretty much normal, but smaller size, right? There's another slide showing the same thing. You need to be able to recognize, just looking at a diagram of this, and know where the obstruction is. If it's variable intercrossing, variable extracrossing, you need to be able to do that. So now we're looking at lung volumes. This particular one, I like to put different examples of diagrams that you can look at, so you can choose which one you like the best. Of course, here they're showing, obviously this is looking at a volume time tracing. It's not a loop that we're looking at. You can see with pulmonary fibrosis, they're showing that there's thickening of the alveolar capillary membrane that are really stiff here. You can see with asthma, they're showing an obstruction there. With emphysema, you have floppy alveoli. Because they're not holding the airways open, they collapse prematurely. So these diagrams, I think, really help look at it. So then you got, here are all your different lung volumes and capacities that are, so there's RV, ERV, there's FRC right here, from there down, so you can look at these and see. What's the other name for MBC? Maximal breathing capacity. Those of you who have lab, do you remember breathing like this? What were you doing when you breathed in and out as hard and fast as you could? What was the test called? MVV. MVV is the same thing as the maximum breathing capacity. This is an older figure. In maximal voluntary ventilation is the same thing as the maximal breathing capacity. So you see the person breathing in, you're breathing in, they're breathing out, they're breathing in. They're breathing in as deep as they can, now they're blowing it all out. They breathe back in. The volume time tracing. What you can see is that this is your reference point looking at this one. And if you look at this for pulmonary fibrosis, look, their total lung capacity is really reduced. Markedly reduced. Right? And so the flow rates aren't that dramatically reduced. Right? If you look at their FRC is reduced as well. It's not really showing the RV very well like I'd like to see it. This is not really showing, this is not diagramming it as well as what you might like to see. Look at this person with asthma. This person with asthma is actively having an attack. Right? They're actively having asthma. And you can see this, remember this dotted line here is representing their residual volume. Here's their FRC. Can you see someone that actively is having asthma? Their RV is increased, and plus their FRC is dramatically increased too. Because they're trapping a little bit more air in their lungs, even their TLC is a little bit increased during their asthma attack. Does that make sense how you can look? Notice their flow rates, the slope of this line is not very great. And if you ask them to breathe in and out as deep and hard as fast as they could, they're starting to trap air in their lungs. They're trapping more air in their lungs. So that's narrowing of airways. In emphysema, you see the same picture here, and that look how big their residual volume is. Their FRC, which is from here down to there, that's really reduced, or really increased, I'm sorry. They're markedly increased. Their total lung capacity is increased. So if you look at this is a good one that sort of shows you what's happened to the vital capacity in this patient with asthma. What's happened to their vital capacity?
Increase.
What?
Increase.
Their vital capacity. It's decreased. This is normal. Why is it reduced? It's reduced because the residual volume is so high. when they exhale, they're trapping air in their lungs. So, if someone that has asthma, let's say, or emphysema, the reason their vital capacity is reduced is because they're trapping air in their lungs. That's what's happening here. Their RV is so darn high. Right? If you look at someone with pulmonary fibrosis, the reason their vital capacity is reduced is because they can't breathe in easily. This is another slide sort of showing the same thing.
I have a question. Like, go back to the slide. I'm so confused, like, when you say asthma, they trap air in their lungs, because what I know emphysema are the one who traps air in their lungs than asthma.
And both of them do. If someone's actively having an asthma attack, their airways are so narrow due to bronchospasm and inflammation, right? What's different about asthma is you get them on medications and this will become normal. Once you have emphysema, there's nothing you can do to make their lungs normal again. So this is during an attack, during an asthma attack. But in between time, the patient with asthma could have normal spirometry. That's our goal. You get them on good controller medications, keep them away from what triggers their asthma, and will be normal. And then here we got, this is sort of showing the same thing basically, another diagram. You don't have to quantify air trapping versus hyperinflation, right? But what they'll do a lot of times is once the TLC starts dramatically going up, that's when they call it hyperinflation. We're not going to bother with that. We'll just be glad to quantify if they have COPD, if it's mild, moderate, severe, or very severe. You already seen this particular slide. So we ought to just stop here. This will be a good place to stop. Remember, I think we did in the first day class, but I went back to here too. Remember, because we're taking the break in the middle and the other reasons,